Fixation using the 3.5 VA LCP Proximal Tibia plate system. In this exercise, the procedure for the fixation of a tibial plateau bicondylar fracture, type 4.1-C3, will be demonstrated using the 3.5 VA LCP Proximal Tibia plate system. Upon completion of this exercise, you should be able to describe the pathoanatomy of a bicondylar tibial plateau fracture, describe the critical importance of preoperative planning based on adequate imaging, and apply the principles of articular fracture treatment to fix a bicondylar tibial plateau fracture using 2 plates through a 2-incision approach. Clinical indications include bicondylar type C fractures of the tibial plateau, which are multifragmentary articular fractures characterized by the involvement of both the medial and lateral plateaus. As a rule, considerable comminution and impaction of the articular surface on the lateral side, and a significant variation in the medial fracture pattern, including frequent sagittal fracture lines and occasional joint impaction. The relative contraindications include acute infection, the detection of an existing soft tissue defect, which would lead to a severe soft tissue defect post-fixation, and severe soft tissue swelling, which precludes the use of multiple incisions and prevents tension-free wound closure. The clinical case shows a 30-year-old patient with a tibial plateau bicondylar fracture type 4.1-C3. The intraoperative image intensification shows the fracture fixation using the 3.5 VA LCP Proximal Tibia plate system. Early follow-up shows maintenance of alignment. The patient is allowed to move the knee through a full range of motion without restriction. In the vast majority of cases, the patient is positioned supine. However, some posterolateral fracture patterns can be managed with a lateral or floating lateral position. Clinically, in this open reduction internal fixation ORIF procedure, C-arm reference imaging of the contralateral knee is taken for subsequent verification of the reduction. The surgical landmarks of this procedure are the patella, tibial tuberosity, fibula head, and the lateral and medial joint lines. Based on these anatomical landmarks, the planned approaches are along the medial and lateral incision lines. The bone model in this exercise shows a large bone block fracture medially with considerable comminution laterally. To repair such complex injuries, 2 separate incisions are necessary. Firstly, a medial incision based on the optimal implant buttressing position, and secondly, a lateral incision which avoids the delicate soft tissue cover over the tibial tuberosity and the fibula head. In the clinical situation, care is taken to achieve the widest possible skin bridge with the minimum possible undermining. The medial incision is directly dorsal to the pes anserinus, which is elevated or partially incised depending on the fracture configuration. After clearing the fracture gap, reduction is achieved by pushing the medial bone block upwards. Clinically, to achieve preliminary reduction, mechanical distraction, changing flexion of the knee, and a stab incision on the lateral side, followed by the application of a pointed reduction forceps, are often necessary. The instruments required for the reconstruction of the medial plateau include the reduction forceps, the K-wires 2.0 mm, the bending irons for plates, the universal drill guide 2.5/3.5, the drill bit diameter 2.5 mm, the depth gauge for long screws diameter 3.5 mm, the hexagonal screwdriver shaft diameter 2.5 mm, the hexagonal screwdriver diameter 2.5 mm, and the drill bit diameter 3.5 mm. The pointed reduction forceps is used to hold the fragment in position. Preliminary fixation is achieved by inserting at least 2 K-wires. Note that the K-wires used for preliminary fixation are inserted close to the joint surface. A 5-hole, 1/3 tubular plate is positioned at the apex of the medial fracture line. The bending irons are placed onto the plate and the plate is underbent to slightly less than the contour of the bone. Observe that slightly underbending the plate helps achieve the optimum buttressing effect. A 2.5 mm hole is drilled just distal to the apex of the fracture. The depth is measured. Here, a 48 mm cortex screw is inserted, initially under power with the hexagonal screwdriver shaft and final tightened with the hexagonal screwdriver. This maneuver pulls the plate into its anti-glide or buttress position, thereby reducing the fracture indirectly. The universal drill guide 2.5/3.5 and the drill bit 2.5 are used to drill through the most distal plate hole. The depth is measured, and here a second 36 mm cortex screw is inserted, initially under power with the hexagonal screwdriver shaft and final tightened with the hexagonal screwdriver. The screw insertion steps are repeated on the most proximal plate hole. Additionally, in order to achieve interfragmentary compression, the cortex under the plate must be over-drilled with a 3.5 mm drill bit. To prevent interference between the screws of the medial and lateral plates, the screw lengths and their trajectories are planned. After each screw insertion, they are verified under image intensification in both the AP and lateral planes. Note, the second screw has also been over-drilled. To ensure they are fully seated, the screws are final tightened with clockwise turns of the hexagonal screwdriver. The K-wires are removed. At this point of the procedure, the screws could be exchanged for different lengths if necessary. Clinically, the reduction and reconstruction of the medial plateau would be verified under image intensification. Note that, depending on the fracture characteristics, different plates can be used medially. For example, the posteromedial or the medial 3.5 mm LCP plate. At this point in the demonstration, the bone model is rotated 180 degrees to access the lateral plane. A distally directed curved hockey stick or straight skin incision is made from the lateral epicondyle over the tibial tubercle. In the clinical situation, the anterior tibial muscle is detached approximately 5 mm away from the tibial ridge. A submeniscal arthrotomy is performed below and parallel to the lateral meniscus, which provides favorable reduction control. In the clinical situation of a lateral bucket handle tear of the meniscus, the tear could now be repaired before continuing with the procedure. Shown is a lateral bucket handle tear of the meniscus. The bucket handle tear in the rim of the meniscus has been corrected with 3 reabsorbable sutures. Observe that the proximal end of the VA LCP tibial plate has 3 holes, which can be used for both provisional K-wire fixation and sutures. The sutures correcting the tear of the meniscus have been threaded through the most proximal K-wire or suture holes of the plate and then tightened. The condyle is carefully opened through the anterior fracture line to fully examine the extent of damage to the lateral condyle. The intermediate fragment would then be reduced and provisionally fixed with a K-wire, the bone defect augmented, and the main lateral condyle reduced and fixed with the VA LCP Proximal Tibial Plate 3.5. The instruments required for the reconstruction of the lateral plateau include the K-wires 2.0 mm, the reduction forceps, the locking drill sleeve 2.8 mm diameter, the universal drill guide 2.5/3.5, the drill bit 2.5 mm diameter, the depth gauge for long screws 3.5 mm diameter, the hexagonal screwdriver shaft 2.5 mm diameter, the hexagonal screwdriver, 2.5 mm diameter, the VA double drill guide, 3.5 for drill bits 2.8 mm diameter, the drill bit 2.8 mm diameter with stop, calibrated, the star drive screwdriver shaft 3.5 T15, and the handle with torque limiting function 2.5 Newton-meters. Note that the 2.5 Newton-meter screwdriver assembly is used for the final tightening of the locking screws. The central impaction is elevated with a pusher and provisionally fixed with a K-wire. The K-wire is advanced through the medial cortex and is then pulled medially until it is flush against the inner wall of the impaction. This repositioning and fixation of the central impaction will facilitate later closure of the primary fracture. Bone graft is compressed into the cavity to support the central impaction. The lateral fragment is reduced and held in position with the pointed reduction forceps. Note that, in the clinical situation, correct positioning of the pointed reduction forceps can pose a challenge. VA LCP proximal tibia plates are available in small and large bends to accommodate varying tibial anatomies, and marked SB, small bend, and LB, large bend. In the clinical situation, both the small bend and large bend trial plates would be positioned on the proximal tibia to determine the best fit. Be aware that the fractured bone may be broadened, leading to misidentification of the best fitting plate. In this case, image intensification of the contralateral knee taken during preoperative planning may be useful for comparison in order to identify the most suitable plate bend. The appropriate sized plate is selected to buttress the lateral condyle. In this exercise, a small bend 3.5 VA LCP proximal tibial plate is used. To facilitate plate positioning, the locking drill sleeve 2.8 mm diameter is attached to the uppermost proximal hole of the plate and functions as a handle to position the plate on the tibia. The plate is provisionally fixed with a K-wire at the proximal end. In the event that the plate is not positioned correctly, the provisional proximal K-wire can be removed and the plate repositioned. In the clinical situation, image intensification in both AP and lateral planes is performed regularly to confirm the correct alignment of the plate to the tibial shaft axis and that the screw trajectories are parallel to the joint in the coronal plane. The plate screw fixation begins with the insertion of cortex screws to achieve compression of the plate to the bone, followed by the insertion of variable angle locking screws in order to lock the plate in position relative to the bone. The universal drill guide 2.5, 3.5 is positioned centrally in the long hole of the plate, and the drill bit 2.5 mm is used to drill a hole through both cortices. The depth is measured. Here, a 3.5 mm diameter, 48 mm long cortex screw is inserted, initially under power with the hexagonal screwdriver shaft, and final tightened with the hexagonal screwdriver. Note that when using a plate with 12 or more holes clinically, the superficial peroneal nerve and anterior neurovascular bundle must be carefully protected. The plate must be correctly aligned before continuing with screw insertion at the distal end of the plate. Clinically, intraoperative imaging in both the AP and lateral views would be performed to verify that the plate is correctly aligned. The screw insertion steps are repeated at the most distal end of the plate and here a 3.5 mm cortex screw is inserted. In this exercise, the plate-to-bone compression is performed proximally with a compression screw. Note that these rarely require over-drilling. Alternatively, a large periarticular clamp can be used. Both the screw and clamp compress the plate down to the bone and potentially assist in narrowing the fracture gap. If a screw is used, the screw insertion steps for a 3.5 mm Cortex screw are repeated. The drill bit, 2.8 mm diameter, is inserted through the locking drill sleeve 2.8 mm and used to drill a path that slightly penetrates the medial cortex. The depth is read directly off the drill bit. The locking drill sleeve 2.8 mm is removed, and the screw insertion steps are repeated to insert a 60 mm length 3.5 mm VA locking screw here. An audible click is heard when the screw reaches the 2.5 Newton-meter limit. The provisional K-wire is removed. For VA locking screw insertion, the variable angle double drill guide is used, at either the conical end for variable angles or the cylindrical end for fixed angles. Note that the VA double drill guide 3.5 cannot be used to measure screw length. The cone-shaped end of the VA double drill guide 3.5 is placed in a plate hole of the proximal rafting row. The 2.8 mm drill bit is used to drill a hole at the desired angle through to the tibial condyle. Clinically, the path of the drill bit is regularly checked under image intensification to ensure that it does not collide with any screws or penetrate the articular surface. The depth is measured, and the screw insertion steps are repeated to insert a 75 mm length 3.5 mm VA locking screw here. The screw insertion steps are repeated and here a 70 mm long 3.5 mm VA locking screw is inserted into the remaining rafting plate hole. The fixed angle end of the VA double drill guide 3.5 is placed in the hole of the second row of the plate at the proximal end. The drill bit 2.8 mm diameter, calibrated, is passed through the drill guide and the hole is drilled. The depth gauge is used to measure the hole length, and here a 65 mm long 3.5 mm VA locking screw is inserted under power with the star drive screwdriver shaft 3.5 and final tightened with the star drive screwdriver shaft connected to the torque limiting handle 2.5 Newton meters. The reduction forceps is removed and the two distal cortex screws are retightened in order to ensure that the optimum buttressing effect of the plate is achieved. As the screw insertion at the proximal end of the plate can potentially loosen the screws at the distal end, it is crucial to verify that the distal cortex screws are secure. The locking drill sleeve 2.8 mm diameter is attached to the distal neck hole of the plate and drilled with the 2.8 mm drill bit until it reaches the subchondral bone of the posteromedial tibial plateau. Note that the whole path is obliquely directed towards the posteromedial tibial plateau. The depth gauge is used to measure the hole length, and here a 60 mm long 3.5 mm VA locking screw is inserted under power and final tightened with the torque limiter 2.5 Newton meters. The K-wire is removed medially. Note that the cortex screw and/or VA locking screw insertion sequence and placement are dependent on the degree to which the plate matches the anatomy of the bone. In the case of very osteoporotic bone, the first cortex screw in the proximal plate end can be replaced with a locking screw, and the screw angle can be varied to optimize screw purchase in the bone or the subchondral support of the repositioned fragment. Additional locking screws can also be inserted in the shaft segment of the plate if necessary. Locking screws can be used to limit toggling in the cancellous bone of the medial condyle without having to protrude through the medial condylar surface, thus irritating the medial collateral ligament. In this demonstration, a bicondylar fracture was shown and locking screws were inserted to improve the stabilization of the medial condyle. In the situation of a unicondylar lateral fracture with good bone quality, only non-locking screws would be inserted. Screw insertion into the second plate row is optional and depends on the fracture location and geometry. In the case that there are unused plate head holes, screw placement must be equally distributed between the proximal and second row of the plate. Depending on the plate length and bone quality, either cortical or locking screws can be used to complete distal plate fixation. You should now be able to describe the pathoanatomy of a bicondylar tibial plateau fracture, describe the critical importance of preoperative planning based on adequate imaging, and apply the principles of articular fracture treatment to fix a bicondylar tibial plateau fracture using two plates through a two-incision approach.